Well, good afternoon, everybody, and thank you so much for having me. I want to take my first few minutes and make some personal comments about the gentleman that just received those awards. You know, for me personally today, with what's going on in Northern California and what's happening with a very small hospital in Paradise, California, I think that we all need to acknowledge the people that we work with side by side every day in the work that we do, that do the work because it's the right thing to do. Not because it's the prestigious thing to do or it brings us a lot of money or a lot of recognition, but because they've decided that something needed to be done and it's the right thing to do. So for me personally, Dan, Don, Mike, thank you very much for just stepping up and doing what's right. Thank you. So the sobering news for us in California is that we are in a crisis when it comes to the homeless population. The numbers are staggering. We have over 134,000 homeless people in California as of the count that is done every year in a report to Congress. That number represents a 14% increase from the previous year. So the numbers just keep growing. And again, when I think about a town like Paradise, we now have 26,000 people that don't have a home because they've lost their homes. Hospitals deal with the homeless every single day, and they do the quiet, good work that's required. What we faced this year was a piece of legislation that was introduced by Senator Hernandez that, if you think about it, made it seem like we weren't doing this quiet, good work every day. And so put some very prescriptive requirements on hospitals as the bill was initially introduced. I'm just going to remind folks just real quickly, when the bill first hit the floor, it required that we give all patients food, clothing, 30 days worth of medication. You couldn't release them during nighttime hours. You couldn't release them in inclement weather. You had to vaccinate everybody. And you had to use, there was a prescriptive amount on your community benefit dollars that you had to use for the homeless. We worked really hard at CHA to try to get to a place where we could have a law now that reflects most of the quiet, good work that you do every day. What we have here today is a stellar panel of folks that are going to tell us what they do, one from California, but two from New York, because I think it's important to hear what folks are doing in other states. Why reinvent the wheel if there's some good ideas out there? So let me introduce our panel members. And then I'll let each of you, we'll start with Jeanette. Jeanette Bogdan is the Director of Ambulatory Care Coordination and Chronic Care Management for Yale New Haven Home Health System. She's going to talk about the medical respite program that she has working with their homeless population. Next, we'll have Carrie Thomas. Carrie Thomas serves as the Vice President for External Affairs for Sutter Health Valley area. And she spends a lot of her time working with that same population and is going to talk to us a lot about the partnerships and the collaboration that they have built for Sutter. Finally, we have Deirdre Sekulik, who worked as a social worker for almost 20 years and has been employed with the Montefiore Health System for the past 10 years, working with their housing at-risk program and medical respite program, and she'll talk to us about that. Each of them will present for about 15 to 20 minutes, and then we'll turn to you. I have a set of questions also, but we'll turn to you to answer any questions that you might have. Thank you.
Good afternoon, everyone, and thank you so much for having me here and being a part of this, honored to be a part of this panel. So, not unlike Dr. Creel, I am not looking forward to going back to Connecticut tonight and getting off a plane to snow. They are predicting snow back there. Matter of fact, I'm going to have to look for that turtleneck I have on in my photo that you saw a little bit earlier. So let me tell you a little bit about Yale New Haven Health System and about the state of Connecticut. Really, when you compare Connecticut to California, it's like comparing a splinter to a plank in terms of size. But the Yale New Haven Health System, we were founded back in 1995. It consists right now of 5 hospitals. We expect it to become 6 hospitals by the end of 2019. It's about 2,500 licensed beds. Of those 2,500, 1,500 of them reside in Yale New Haven Hospital. We are affiliated with the Yale School of Medicine at Yale University. Unlike other large health systems that are affiliated with the university, we actually have separate bottom lines. We are not endowed by the university. We have several community partners in other hospitals in the state. Our revenue, our net revenue is at about $4.3 billion, and we are actually the highest taxpayer in the state of Connecticut. We are taxed on our revenue. So just to kind of shed some light on the state of Connecticut, if you look at the median annual income for the state of Connecticut, almost $76,000, which is a pretty healthy median annual income, but don't be surprised by the fact that we serve urban communities, Bridgeport, New Haven. We are the only hospital in the city of New Haven, and if you look at their annual median incomes, you know, in the case of Bridgeport, it's $43,000. In the case of New Haven, $38,000. So, though at first glance, the state of Connecticut would look like one of the wealthier states in the United States, that's not the case. Matter of fact, if you think back to the earlier slides, when he showed on food insecurities, New Haven, Milford ranked number 9. And that's the community we're serving. We also, in terms of the payer landscape, it's not getting better. We, more than half is government. Connecticut's one of the diehard states, one of the last few. We do not have managed Medicaid in the state of Connecticut. It is a fee-for-service Medicaid. About almost a quarter of our payer mix is Medicaid, about 40% Medicare, and little more than 35% commercial, and that commercial number is decreasing. If we look at Medicaid, we're paid about 23 cents on the dollar for our Medicaid patients. So what are solutions we can collaborate with community-based organizations to help reduce readmissions, length of stay, ED visits for people experiencing homelessness in our catchment area? So, you know, I like to think about from a revolving door to recuperation. When you look at the homeless population, I think of it, it's like a revolving door. They are often coming for refuge to our hospitals, seeking refuge at our hospitals. And medical respite really will help fill that void that the homeless experience when they are discharged from a hospital ED for an inpatient stay. And who benefits? Well, first and foremost, the patients. As Peggy said, we've got to do the right things for our patients. And what patient doesn't deserve a warm meal in their belly and a safe roof over their head? Medicaid, in terms of reduced spending, and of course the hospital. You know, as I said, Yale New Haven Hospital is actually the only hospital in the city of New Haven. And if I look back over the last several months, you know, back from July, every week we've been at a surge level, where at any given time we have in excess of 25 people in our ED waiting for a bed. So it's important to, you know, have the right people in the right bed at the right time. So in terms of background, the population of New Haven is about 130,000 people, so about 3.5% of the total population of Connecticut. But when you look to the homeless population, we comprise 16% of the state's homeless population, on average close to 700 people. We know that they come to us with many complex medical issues, many social needs, many behavioral health issues. And we know that they suck up a disproportionate amount of Medicaid and hospital resources. They require a higher level of care for more days, increased readmissions, and I cannot stress how many more emergency room visits, particularly as we get into this time of year where the weather in Connecticut is not like this, and people are seeking to get out of the snow and the rain and the cold. So how bad was it? Dr. Kelly Duran, a Robert Wood Johnson scholar, back in 2012 studied 113 homeless people over the course of 30 days and saw that they had a 70% rate of return to the ED during that time. Over 50% were readmitted to inpatient care and 3% for observation. So 75% of these readmissions occurred within 2 weeks. So when you think about good post-acute care, you think about getting people care within 7 to 14 days post-discharge. And that's for anybody. So it's that much harder to get homeless people into primary care providers or specialist or follow-up care. And so we saw 75% occur within the first 2 weeks when normally that shouldn't be happening. We know, evidence-based tells us if we can get these people care within 2 weeks after their discharge, they're much less likely to be readmitted. And when you compare that number, it compares to only 18% of an adult Medicaid patient versus that much higher rate in the homeless population. So we partnered with Columbus House, which is a homeless shelter in New Haven. We started this program just 5 years ago, October of 2013, 12 individual rooms. Not a huge number of rooms to meet the need, but you know, I tell people don't let perfection be the enemy of good. You've got to start somewhere. It's got 24/7 staffing and supervision. We provide 3 meals daily. What's important is we have case management working with these people to focus on housing and getting them more permanent housing. We have patient navigators who work with them on their social needs, including transportation to appointments. We have visiting nurse services for them for medication management, and obviously transportation to their follow-up appointments. This has really helped us in terms of those people who we couldn't before discharge because they may be on IV antibiotics or they may require wound care. And if it's a homeless person, where are we going to deliver those services? So the workflow is, our system uses Epic as our electronic medical record, and we identify them as having no fixed address in New Haven. That's a key to us, that that person is homeless. We also go through an interview process with that patient, and we have social workers and case managers working in collaboration with the Columbus House staff on a plan to determine their eligibility. Do the application form with them, arrange for home care services, medication management, verify insurance benefits, and essentially have a safe, coordinated transfer to Columbus House for medical respite. And our results is we saw inpatient readmission rates drop from a little over 50% in 2012 to 16.7% in 2016 for homeless who were discharged to respite care. If we compare that to homeless who did not go to respite care, it was 31%, so dramatic difference. We saw ED and observation visits go down. We saw average length of stay drop from 10.6 days in 2015 to 7.1 days in 2015 to 2016, and with an associated $300,000 reduction in direct costs for the care of these patients. So it's, you know, estimated on average that these people save Medicaid between $12,000 and $25,000 in the year following for all Medicaid claims processed in the year following that respite. So we're very happy with those results. We continued the program. We've expanded the program a bit. We now have an APRN based at Columbus House to help with some of their other chronic illness medical needs. But how do we get ahead of the game? How do we go upstream to help solve for some of these problems? And and in some ways prevent homelessness. So we've kind of got two models that we've been testing in the ambulatory environment. One is the Community Advocates Program, which is based out of Bridgeport and with Northeast Medical Group, which are the employed physicians of Yale. It's about 60 primary care practices from New York up through Rhode Island. And then the Accountable Health Community. So we are the recipient of a CMMI grant, Track 2, for the Accountable Health Communities, which I'll talk a little bit more about. So community advocates, you know, we're all looking at economically feasible ways to start new programs. And so this program actually utilizes a volunteer student workforce. We've partnered with local undergraduate programs, pre-med, social work, and we have students who are doing volunteer work. And this is not their clinical hours for their program. This is actual volunteer work. We see this as an opportunity to develop the future healthcare leaders of our country. And so they are actually screening patients for social determinants of health, including housing insecurity, food, transportation, childcare issues. And when someone screens positive and says that they want our help, they are doing the navigation work. You know, of course, we have like what I call a super navigator or a navigator manager who is overseeing the work. It's about 20 students that we have at any given time. And we're having tremendous success with this program. These students are like a dog with a bone. They do not give up. Within 2 days of the screening, they follow up with the positive screens, and they follow up with these people at least once a week to ensure that they are connecting with community resources. The Accountable Health Communities, which is a New Haven model, is a little bit different. As I said, we're one of 34 sites nationally to be awarded this. It's $5 million over 5 years, and it funds 5 navigators. And it gives us the opportunity to test navigation with the Medicare and Medicaid population in the greater New Haven area. And we've also had the opportunity to partner with FQHCs, 2 large FQHCs in the New Haven area. So we are, all 3 of us are partnered on this. The thing with this program is when someone screens positive, they are randomly given to navigation, or they may just be handed a list of community resources. So, you know, it's an opportunity for us to do a little research for CMS. I will tell you, based on my experience, I could tell them what the outcomes are going to be. The people who get the piece of paper are not going to do as well as the people who get navigated. You take someone who is so incredibly stressed because they're worried about putting food in the mouths of their children, they're worried that they are working 2 jobs and they have child care for their children, or transportation, or a mechanism to pay for prescription medications. And in truth, this is not just the Medicaid population. Don't be surprised. A huge number of these are our own commercial population. You know, many people now in high deductible plans, a lot more out of pocket for people, as well as our senior population. And so we're leveraging these community partnerships to collaborate. So early results for the Community Advocates Program. My advice to people, partner with your finance department. We partnered with our finance department on this, and we looked at the first 100 people who were screened, 121 people screened, 100 screened positive. Of those 100, 80 said they wanted to be in the program. We looked at cost and utilization individually for these patients. We went back before they enrolled in the program and 6 to 12 months after they enrolled in the program. And we found that collectively we decreased the number of ED visits. Collectively, they had 19 outpatient cases per month. We dropped that down to 13. But I think what was really more important or more telling was the level of the ED visits, because before they were enrolled in the program, many of these were low-level ED visits, things they could have, should have gone to their primary care for or could have gone to an urgent care center for. And they now were not coming in for those. They were coming in for higher-level visits, so chest pain, things that really warranted an ED visit. I think the other thing we looked at is financially is we saw a dramatic increase in the contribution margin for those patients after they enrolled in the program. So it was advantageous, first and foremost, for the patients, got to do right by our patients, but also for us as a health system. The accountable health communities, the full-fledged program only started a month ago, but we did some testing, and not surprising, 58% of the 162 people we tested with had at least one need identified. And what we have found out is when you screen people and they come up with one thing that they're positive for, and you start to work with these people, trust me, there's more. There is definitely more. One thing, you open up Pandora's box, but that's good. We see that food is the largest resource need in the New Haven area. Interestingly enough, when we look at the Bridgeport area, we actually find utilities are the biggest need, so slight differences. Our lessons learned, this is hard work. It is not for the faint of heart. It's very challenging. We have found that, many of our patients have subsidized government phones. When we try and communicate with them at the end of the month, they don't have minutes left on their phones. We learned that the hard way. So we now try and front load our communication at the beginning of the month, but we've now also gone to more texting, which is minimal on these government-issued phones. We also find that other than food pantries, with respect housing, it's no wonder there's so many homeless people. There is not adequate housing choices for people in need of housing, particularly safe housing. We've become best friends with the Department of Health, sending them out to places, particularly people with asthma, and are having an extreme number of asthma exacerbations because they're living in unsafe environments, environmentally speaking, rodents, roaches, asbestos, you name it. It amazes me. And then educating patients and providers on what we are and what we aren't. It's interesting, some people, they get wide-eyed and they want to partake, and they ask, how much money are you going to give me? And when we tell them we don't have money for them and we're not handing you dollar bills, they walk away. They think that money is the only answer to solve these. But it's kind of like, do you give people fish or do you teach them to fish? It's working with people on how to overcome the challenges they're facing in their life so that they can take care of themselves. Also, sometimes there's a lot of confusion between community health workers and social workers, and where the line is drawn. Our community health workers, our navigators, our students, we don't work on mental health issues. We work in collaboration with social workers and behavioral health specialists to work on the behavioral health issues. Resources, we've learned it's very important to vet resources before making a referral. We learned that the hard way. We sent one of our very first referrals, we sent to a food pantry. In particular, this woman needed a referral to get a protein. She couldn't afford protein. And so we found a specific food pantry that could supply meat, and we sent her to that food pantry. And she was treated really poorly and walked away without anything. And when the student followed up with her, when we found this out, we went back to that food pantry, and we found out that they had a volunteer workforce. They were desperate for as many people as they could to work there, and so they were not necessarily overly pleased with their workforce, and they were pleased to get the feedback. They rectified the situation. We did have the woman go back and get supplied with what she'd gone for to begin with, but that's why it's so important to have that follow-up. You can't just give somebody a list and expect that they have the time or the inclination to follow up with a telephone call or a visit to a food pantry. You have to find out what are their challenges and what are their barriers to actually making a successful connection. We've also found there's stark variation between types and numbers of resources from community to community. We spend a lot of time just inventorying our resources. As far as the student recruitment and engagement, I'm really happy to say our first student is now in medical school. We're trying to track their futures, and we're thrilled, and we feel a part of it, as we were listed on her application to medical school. But you need to keep them engaged as well. We spend a tremendous amount of time on recruiting the right students and then onboarding them, training them in motivational interviewing, and keeping them engaged. So offering them the opportunity to have a lot of shadowing experiences. So the secret sauce is follow-up and personal engagement, whether it's engagement with providers, with patients, with nurses, with community health workers, with community-based organizations. It's truly key. So thank you, everyone.
Good afternoon. I'm Carrie Thomas with Sutter Health, and I am Vice President over the Valley area for External Affairs. So I oversee community benefit, government relations, and community relations for 13 counties, and then work on a number of system projects, including mental health, and some of our advocacy related to the poor and underserved. I have been at Sutter Health for 20 years. My standard joke is I was 6 when I started, ha ha ha. And I grew up in community health. I started overseeing 3 counties and really implementing SB 687, which is our community benefit legislation. So have a real passion for connecting community health to kind of operations and who we are as a business and how do we partner with people in creative ways. For those of you who don't know Sutter Health, we have approximately 70,000 employees and physicians, over 28 counties serving 100 communities in Northern California. Hospitals and care centers. We have a number of care centers, walk-in clinics. All the same, you're going to hear the same themes. I have been doing this work a long time. Right by patients first. We say right care, right place, right time. It's the #1 thing we do. If we can tie it to our operations and inpatient and outpatient data to make a difference, that's important. You eloquently said partner with your finance department. I say win the hearts of CFOs, because I realized early on that going to CFOs and showing that connection was important in order to leverage our community health dollars in a meaningful way. Population health management, social determinants of health, there are a lot of real catchphrases that we like to use in the business. What that really means is it's not a medical first model. That never works. I have had a number of programs where I've failed fast. And I failed fast because I was trying to treat people's diabetes, and I was trying to make sure that they were connected to primary care and mental health care. And when I failed and had CEOs saying, we invested all this money, why is it not working? It was because the individuals had 30 warrants out for their arrest, and that's what stressed them out. It was, I'm sorry, we've been dealing with a lot of smoke, so bear with me as I fight through this. It's that their pets, they didn't want to leave their pets back when housing, kind of no barrier to housing existed. So really understanding that although we're healthcare systems and we're investing in the health of the communities, that's very broad to make sure that we can engage people. And also defining clear responsibilities. We partner with a number of nonprofits, including federally qualified health clinics, navigators, education institutions, making sure that we can be first and foremost a healthcare system providing quality, affordable healthcare, right place, not urgent care centers and emergency departments, and that we bring people in creative ways in order to serve the population that we're trying to serve. So just in the Valley area, which is 13 counties, we invest cash dollars 16.7%. Total Sutter Health community benefit investment is $620 million. I'm really distilling the cash investment in these programs that are serving the population. And you can see we have measure, measure, measure first and foremost. Again, patient first, not operational, benefit first. You can see some of those outcomes. We too started an interim care program years ago. It was one of the first programs I started as a community benefit manager. And I walked into a room of homeless advocates and elected officials, and I was yelled at. I went into the lion's den for 45 minutes. I was yelled at saying, you know, people were being discharged from the hospital. They were walking on a bloody stump, 5 miles in order to get care. And it was really fun to create this collaborative program and come together and really understand the challenges. We now have an interim care program throughout many of our communities. I have, you can see again, some of our benefits. I think when you provide wraparound services, we all know it. We all continue to talk about it, and that's good. Wraparound services works. It also takes an investment. So I have a video of our interim care program and one of the clients that we served.
Carpentry is, for me, it's an art form. The beauty that the wood portrays, all the different grains, and there isn't basically anything that I can't do with wood. I was living with my daughter in Sacramento. Because of my drinking, I wound up having to leave the house and went homeless. One day, out of nowhere, I was struck by a vehicle, and everything was just black until I woke up in the hospital with intravenous tubes and under high medications. I was bad. They said, Mr. Hernandez, we have to release you. And I'm like, wow, you have to release me? I can't go back out to the street like this. And they said, no, you're not going back to the street. We're referring you to ICP. And I didn't know what ICP interim care program was.
An ICP Plus patient is a person experiencing homelessness who's been recently discharged from the hospital, and they need somewhere to recuperate while they recover from whatever medical condition caused them to be hospitalized. ICP Plus is a collaboration between WellSpace Health and Sutter Health. It would not have been possible to operate this without contribution from Sutter Health, both for operational support as well as financial support.
They made sure I took my meds and vitals every day. I was made to be comfortable.
Sutter Health is able to refer the patients to us to get that case management wraparound and that nursing support. Enrique is a great example of a success of ICP Plus. We were able to connect him with outside resources, getting him his ID and securing income, and eventually being able to refer him to the Mather housing program that he's in now.
I just received employment, and it's a construction company. I'm going into a world that I'm in love with. And even though I don't have my family at hand now, I'm trying to repair that. I do have me. I'm hoping that later in the future, I'll be able to establish my handyman service again, which will be the totem of my success for me. ICP was wonderful. Without it, I don't know where I'd be today.
And an interim care program looks different in every community we serve. Sometimes we partner with shelters, sometimes we get a house and have a house manager. It really is around the services that exist in the community and how we best can bring those partners into the work that we do and within the walls of our hospital. We have a number of meetings with our case management, nurse directors, our medical directors of the emergency department, different hospital, med-surg floor mostly, in order to talk about how do we make sure that we're referring the right patient and how do we make sure it's seamless. And we don't have to do it all, and that's what's really powerful. From there, From there, we expanded into the ED navigators, again, bringing federally qualified health center case managers into the walls of our hospital, using our Epic electronic health record in order to identify those patients that are in for non-urgent needs, maybe coming in a number of times in a row within 6 months or a year, and connecting them at the time of the visit to a federally qualified health clinic in order to change their use behavior. So we serve nearly 450 patients across Placer, Sacramento, and Solano counties annually, and we see a 76% reduction in non-urgent ED visits. And finally, we kind of took all of the work that we're doing around homelessness and 2 years ago launched a Getting to Zero campaign. And this really was around looking at homelessness beyond just a specific city or county and looking at homelessness as a regional issue. We started with Placer, Sacramento, and Yolo counties because of the movement of the homeless population across county boundaries. We actually have visited a number of communities across the country. I had the opportunity to meet Dan on a site visit in San Diego with our mayor of Sacramento to learn the work that they're doing, and we're trying to get a pop-up shelter now because of the outcomes. So congratulations, it was a well-deserved award based on what I saw. And really looking at how do you bring together elected officials to have a regional conversation around how to end homelessness. We did 3 convenings, 47 elected and appointed officials across the cities and counties of those 3 areas. We brought together homeless coordinators. We're sharing data. We're talking about how we're moving forward collectively in reporting and really using those best practices. We've invested $2 million to 4 government jurisdictions that have served 2,500 clients, everything from vouchers, so those individuals that have been given housing, but the voucher isn't ready. So how do we fill that gap so we don't lose the house? We live in California, and frankly, there are a lot of things that come together in California. Expensive housing, lack of housing. We are a more liberal state government. There are things that are a challenge. It just is a fact. And so how do we make sure that people are getting sheltered and moved through the system in a low barrier way? And that really has come out of Getting to Zero. We also invested an additional $2.3 million with the city of Sacramento in order to do a shelter model. And we're looking at matching. So this was really new with our community benefit dollars. We've never done this really in my history in releasing $10 million in community benefit dollars and matching $10 million, and for private donations and new government money. So governments that stepped forward in order to address housing, the dollars had to be new. It couldn't be existing dollars funding homelessness. And I was surprised at the communities that stepped up early and came up with really innovative ways in order to address the homeless in their communities. Communities that weren't talking about it before, because when you talked about it, the idea was that you brought them to your community, right? So it's been a really interesting project. We have 1 year to go. We are almost out of funding, which is kind of exciting. We're working on some more private donations. And I do have a little video to show you on Getting to Zero.
More than 4,000 men, women, and children in the Sacramento region live in locations not meant for human habitation, under overpasses, in makeshift campsites along the river, in cars, out in the open in parking lots. You've seen them. You've tried not to make eye contact. People become homeless due to many reasons: disability, escaping abuse, transitional age youth, formerly incarcerated, unemployment. The reasons are varied, but the impact of homelessness is the same: compromised health, overwhelmed emergency services, a blight on our community. It is not hopeless. We can end homelessness. There is a solution.
My name's James Conforti. I'm the president of Sutter Health's Valley area. We're very proud to be one of the oldest headquartered companies in Sacramento. We're very committed to providing care and support to the people in the communities we serve and feel that that extends beyond the walls of our hospitals and clinics. As I speak with business leaders around the community, the issue of homelessness comes up time and time again, and often it's right in front of their business doors. I think it's critical that we take a regional approach to this problem because it's a problem that we share across jurisdictional boundaries, and especially in times of constrained resources, no one has enough resources to do this and address this problem on their own. Sutter Health felt it important to take a leadership role in this effort because it's a problem that we share. Well, we have partnered with business and government leaders across the region to align resources and commit to standardized outcomes aligned with the Housing First model, targeted at the people most vulnerable, wrapping services around them and helping us get to zero.
Our goal is to reach a moment we call functional zero, and that's where we have equal to or greater number of housing and services to match than those experiencing homelessness in our community. So at Sacramento Steps Forward, for the last 2 years, we've worked hard with our community partners to develop a system that's under the Housing First principles. This is where we meet people where they are, work with them as a partner in accessing services and housing, and in that process, we reduce barriers so they can have the greatest potential for success. And in that environment, we believe we will be successful here in Sacramento in ending homelessness.
Sutter Health has already made matching grants to government entities to help with funding in some of the programs that they've already gotten started with. Sutter's also committed to working with the business community to raise up to $20 million to help deal with some of the gaps in the continuum of support for our homeless population so that we can appropriately deal with the vulnerabilities that people are challenged with.
We do have a grant that we received recently called the Whole Person Care Grant. It is $10 million grant funding. But unfortunately, we couldn't use it for housing for the homeless. It is for chronically mentally ill folks in our communities, but could not be connected with that need for housing. The Sutter Health Grant really is focused on that missing piece, that housing piece. And if you can't give housing to the folks that you're trying to assist, it's just really kind of a pointless effort. And so Sutter stepping forward with the $1 million that they brought to the table absolutely filled in that missing piece.
This is a regional problem. We're not going to be able to solve this on our own. No government can do that on its own. We need partners who are nimble and who can help us push the boundaries of what we do. And partners like Sutter will help us do that. Sutter has been a great community leader. What their money has done is 2 things. One, more beds, so more people under a roof, and then more time for those shelters so they could be open during the day so people don't have to get out at 6 in the morning.
One opportunity we have in our region is we are all about innovation and trying new things. Sutter is one of the most innovative companies in the region, and their nonprofit leadership has been extraordinary in a wide range of areas. We need the kind of leadership outside of the box and bringing non-traditional players and unexpected allies to the table. There's really no one better at that than Sutter.
By working together, we can end homelessness, collaborate through public-private partnerships, align regional resources, focus on housing and ongoing support. Join us. WeCanGetToZero.com.
And one thing that came out of Getting to Zero was a street nurse navigator. And we have another video on that GettingToZero.com if you want to go and check it out. It started with Amanda, the first street nurse, and we're now up to 4 in communities throughout the Valley area. She straps a backpack on her back. She's employed by a federally, or the nurses are employed by a federally qualified health clinic, and they go out and build trust, but also provide immediate medical care to people living on the street. It was one nurse for a very long time, and we got a lot of publicity, and people were very interested in it. It's something that people are very attracted to. It really does work. Yes, the medical care is important, but it's another first kind of connection with people to build that trust, to move them into a system of care. So Sutter is really proud to be a part of our community. We're really proud to look at unique ways. We step out. I have supportive leadership for my team to step out and do things and fail quickly with well-known, trusted partners in order to address this issue. And it's really been a pleasure to work in this field for 20 years. So thank you.
Hi, everyone. I think Carrie said it best with this is it's very repetitive. It's what we do. I feel like, what we're doing in the Bronx in New York is almost a mirror image of what Jeanette is doing in New Haven. So here's an overview of the Bronx. We are the poorest urban county in the nation. We have high rates of chronic illnesses. We have our median household income is $34,000. 80% of our healthcare costs are government payers. We have high rates of undocumented patients also. And out of 62 counties in New York State, we scored 62 in health disparities. So really, really complex medical issues and also complex psychosocial issues. This depicts what, the typical homeless patient looks like coming into the ED, and I will say this is done by my colleague, Dr. Kelly Duran, who's now at NYU. And what we were finding when we originally started our program was we were having really the high frequent flyers, the high utilizers of the ED. Most of them were street homeless folks or shelter folks. They would get admitted into the hospital in New York. It's very difficult to discharge somebody from the hospital to a shelter. There's very strict regulations. It takes a very long time. It could take at that time maybe up to 6 weeks to discharge somebody from the hospital to a shelter. What would happen is we would discharge them, the Department of Homeless Services would agree finally to take them. We would send them, the patient wouldn't show up at the shelter, or they'd show up at the shelter, and then the next day they would be back in our emergency room, particularly in the wintertime, New York, New Haven. We're expecting snow tomorrow. We have a lot of patients who would use this and would use the hospital as a form of housing during the winter months. So our hospital sought to break this cycle in some way and see what we could do, and therefore created our program. This is taken from 1018. This is the shelter census from the Department of Homeless Services in New York City. It's for the 5 boroughs of the city, so it doesn't cover the state. And this is not an accurate number. New York City really went up in arms when we reached 60,000. They never thought they would reach 60,000 people in shelter. This is not homeless people, this is people in shelter. Every night at 10 o'clock in the city shelters, a census is taken. It's reported into the Department of Homeless Services, and this is where this number comes from. It doesn't include folks on the street. It doesn't include folks in what's called drop-in shelters or safe haven shelters. It definitely doesn't take into account folks that are in our emergency room. And we do a Hope Count, a point-in-time study also in New York City the same night that the Department of Homeless Services does their Hope Count. And we do it in the hospital emergency rooms in the Bronx. And for the last several years, we've conducted it same night, same instruments used by the Department of Homeless Services, and we've actually found more people in our ED that are not even registered for care. They're just in the ED, sleeping out, getting a sandwich, then the city is counting on the streets. And it's usually the last Monday in January, so it's usually a very cold night, so our EDs are usually full of people. So everybody in this room, this has bounced around, as Carrie said, numerous times, social determinants of health. Where you live or where you don't live has a significant impact on your health outcomes. I like to include it because I want people to also look at the other aspect of housing and health, that your health also affects your housing. And what we find in the Bronx is lots of people, lots of folks that are getting a chronic illness, they're living paycheck to paycheck, they're the head of household, they may come down, they may get COPD, CHF, they may get a diagnosis of cancer, and now their whole stability of their housing is affected because it could take you 6 months to 1 year in New York City to get disability, and no landlord is ever going to wait 6 months to 1 year for rent. So we're finding a lot of folks, what we've coined as becoming medically homeless. They're not the traditional street and shelter homeless folks, but they're the folks that don't qualify for some of the housing in New York City, the supportive housing, which is prioritized for people with a severe mental illness and for substance abuse. So these are folks that just got sick, can't work, and now are facing evictions. So our program started in 2009, and back in 2009, we were seeing really a high influx into our emergency room, lots of issues with getting our folks into shelter. And at the same time, one of our community partners that we work very closely with that runs our homeless outreach team came to us and said, we're also having difficulty knowing that when one of our folks comes into your emergency room or comes into your hospital, we don't know what happens to them. They disappear. It's a very big, our hospital is over 3 campuses. It's a very big system. They can't find the folks that they're looking for that maybe belong to their drop-in shelter or that they know from the street and that they're providing care with. So we came up, we studied, the ED, we studied who was coming in, we tried to figure out how could we actually identify a homeless person coming into the emergency room. And we really wanted to try and avoid the use of episodic care. Our real goal was to link people, like everybody has said, healthcare first, patient care first. We wanted to link people to primary care. We wanted to have an effect on their health outcomes. We also wanted to assist the hospital in reducing unnecessary usage of the ED and in reducing unnecessary hospitalizations and length of stay. So the program works in a number of ways. We have an alert system built into our registration that I'll talk about in a couple of minutes. The hospital invested in a team, in a housing team. I oversee the team. It's small. There are 3 of us, but really housing specialists. And what we found was we rely heavily on our ED navigators and our ED social workers. We're staffed with navigators and social workers 24 hours a day in the hospital, 7 days a week. But these folks could not leave the hospital. And as everybody has said, handing somebody that is homeless a piece of paper, they're homeless, you can pile onto that maybe a mental illness, maybe a chronic illness, and the expectation of them to try and navigate very difficult, complex systems such as our HRA system in New York, where you have to get your benefits turned on. Lots of housing in New York, you need a birth certificate, you need your social security card. It's very difficult for these folks nobody carries that around, and it's difficult to get it replaced. So our housing team has the luxury of working with folks in the hospital and then continuing to work with them into the community and try and link them to permanent housing. And we found out these things, like everybody else, the hard way. We sent people to get documents. We trusted they would go. They either could not go, or you give them a Metro card and they're going to use it for something else, or they're going to sell it. And just when we took them actually by the hand and sat in with them in some of the systems, it was difficult for me to navigate some of those systems. So the idea that somebody very vulnerable could navigate them was impossible. We take people, we've seen a big shift from our street and shelter homeless folks into our folks facing eviction, who come into the hospital, who are in the hospital for an illness, and then, on the day of discharge, of course, tell our social workers on the unit, I can't go home, or I have a housing court order, or I haven't paid my rent in 6 months. Or we have people who have been living doubled up in their cousin's apartment, their aunt's apartment, and now they can't go back, all the couch surfers. So we get referrals from our units, from the doctors, from nurses, from the floor social workers. Anybody that will bypass our alert system can be still referred in, and we will triage the cases and manage them. And ultimately our goal, of course, is always housing. We do have some folks that, due to their status, they're undocumented, that shelter and getting them back to shelter will be their only option. So the alert system, we built into our registration, our ED registration system, triggers. We put in the name and address of every single shelter in the city. We also put in the name and address of all of our primary care clinics, because some folks would show up in the ED and they would give their doctor's office as their address. So if they do that, it will still trigger an alert. We also have some providers, like Carrie did, that, some physicians that go out, they're paid by our hospital, but they spend half of their time out on the street providing care on the street to homeless folks. So if somebody comes in and identifies one of them as their primary care, it will also trigger an alert. And the alert is in real time. So it's an email alert that goes out to all our social workers in the emergency room and to our navigators. And additional alerts if that patient was admitted, and another alert would go off to the inpatient team. If they're discharged, the alert would come out to our housing team to say this person has been discharged and that we can follow them in the community. So this is an example of what the email alert looks like. It will give us 12 months of utilization in any of our emergency rooms. It will say whether or not a person was admitted. and the reason they came into the ED. And this is really important for us as a housing team because I get this on my cell phone and I can quickly see what type of housing this person is going to qualify, if they'll qualify housing. There's housing in New York City through the Medicaid redesign team. About 5 years ago, the governor put Medicaid dollars into housing. And if you have high Medicaid utilization, you can qualify for housing through the MRT system. So I can quickly see if this is a person that will qualify for that. The blank space at the top, at the right-hand top, was a text box. So we have the ability of putting a little message into this alert. So if I'm homeless and I show up in the ED and I trigger an alert, the message could say, please hold Deirdre until like 8 a.m. because one of my team is working with me for housing, or please get an updated psychiatric report. We've even used it for some patients that they have gone to other hospital systems, and through our RIO, we've seen that they've had, incidental findings on maybe, a kidney scan, and then we've put in, please check, their ED report from the last hospital. We've had some folks that are, of course, drug seeking, and we had one person in particular who identified as a sickle cell patient and would come in asking for Dilaudid. We had in her text box, please do not give her Dilaudid. She does not have sickle cell. And this can be printed out and given to the ED physician because anybody in an ED, you cannot look through 12 months of a record. So, this is our outcomes. We thought when we started off we would have a deluge of alerts, but we average about 2 a day per hospital. Through linking people from our program, our admission rate dropped from 23% to 14% just by linking people to primary care. Like the other 2%ers said, lots of people were coming in they ran out of, their inhaler, they've asthma, they ran out of their pump, they're sitting in the ED. We've reduced our length of stay from 7.4 to 6.2 days, and our team of 3 in the last 14 months had 58 intensive cases that we managed. Several of these were actually folks that were trying to get on the transplant list for kidney transplant and for liver transplant. And you cannot get on the transplant list. It's one of the criteria unless you show stable housing. So we had several folks who were in housing court and couldn't get listed. So we worked with our community-based partners to get their rent the arrears paid off and get them back listed for transplant. We linked 20 people to permanent housing. Some of that through the Medicaid redesign money, some of that through supportive housing that already exists in New York, and prevented 8 evictions. And the transplant patients is why it says potential life and death. We actually went to court to advocate with some of the judges to say, if you issue the eviction notice on this patient, they will not get transplanted, and they could potentially lose their life. We realized that, I would also like to say, one of the outcomes that we didn't anticipate was staff satisfaction. It really, we polled our staff after we ran the program for the first year, and staff initially, we had to do a lot of training, and we're very, they thought it was going to be extra work in some way for them, so they weren't too happy in the beginning, but I think that Pandora's box that the other presenters have spoken about, our folks were not, our social workers on the units and our nurses said that they weren't delving deep into questions with patients about housing, about their housing issues, and they weren't doing it because they had this worry, this moral distress that I'm asking you to tell me all of these questions, all of these answers, and there's little that I can offer you. So they felt a burden on themselves that here I am, I'm asking you everything, and I have nothing to give you. And what they found was, now that we actually have a program in place, they're asking those questions. They're getting really detailed answers for us, and they're saying to the patient, hey, we do have a program. We can give it. So staff have been really, really responsive to us. We realized very quickly that it takes a long time to house a patient. It could take 6 months to maybe a year to maybe longer. And of course, we can't keep a person in the hospital for that length of time. So we partnered with Community Life, which is a multi-service agency in New York. They provide housing. They also provide substance abuse programs, mental health programs. And when we went to them, they had actually space on the ground floor of this building. This was a safe haven shelter run through HUD. And they had empty space on the ground floor, and we spoke to them about the possibility of kind of a step-down unit, a respite program where we could place patients, and they could stay there while we work on housing, or we work to get them back to the shelter. As everybody has said, you cannot, like DHS in New York City will not let you back in shelter on IV antibiotics, with a colostomy, with a PICC line, with a PEG. So folks that could go home, if they had a home to go to, had nowhere to go because of the shelter regulations. So in 2012, we contracted with them for 2 beds. We started off small with 4. We actually have 8 people in the respite program as of today. We have the ability to get overflow beds. And really, we wanted to put patients in here for a number of reasons. Patients, of course, shouldn't stay a day longer in the hospital or an hour longer in the hospital than they need to. It's not a safe place to be. It's not a healthy place to be. We wanted people to have a safe space to recuperate and to work towards housing from that. I think the luxury for us in that we agreed with Community Life, we will pay you for these beds regardless of whether we use them or not. We don't have like other respite programs. We ideally would like to get somebody in and out in 90 days. But if we can get you in 120 days to permanent housing, we're going to keep you in respite for 120 days because the goal is going to be permanent housing. In the respite, Community Life takes over the case. So our hospital sends the case to them. They take over for case management. They will link people to housing. They'll provide them meals like the other programs. They'll bring them to their doctor's appointments. They will make sure they have their medications. It's not a medical respite program. It's what we would consider a social respite program, but there is an ability to have home care services on-site, physical therapy, visiting nurses can go on. And we really had to, and we've changed this over time and honed it down to do a better job with our criteria, admission criteria. When somebody refers somebody to respite, it comes to our team. We vet the referral. We actually go and interview the patient. We want to make sure that this patient, the most important thing, the patient will do well in the respite program, that they're at a level of functioning where if they had a home they would go home to, that they don't need extra care, that maybe would be a skilled nursing facility. And we also want to make sure that they have a viable plan to get out of respite. If we just fill respite with patients that are complex, it's going to become another shelter, and we can't do that. After we vet the referral, actually a rep from Community Life comes on site and also interviews the patient. So these are our outcomes from last year. We had 8 admissions, 12 discharges. Our average length of stay was 180 days. We don't just take homeless patients into the respite program also. We've had a couple of folks that, were stuck in the hospital, came in, can't go home because they were hoarders. Their apartment needs to be decluttered. They don't qualify for a skilled nursing facility. So we have taken them into the respite program while we get their apartment decluttered. One of them was there for 8 weeks in respite because, of course, when they did the decluttering, they found, holes in the wall, numerous repairs. But he would have sat in the hospital for 8 weeks because we had nowhere, he had nobody, and we had nowhere to discharge him to. Lots of the health issues, COPD, cancers, mental health, of course, diabetes. We had one patient who we were able to put in respite and then link to housing, who was a frequent flyer, who was type 1 diabetic, who constantly told folks in the ED that he was going to stay with his brother or he was going to stay with his friend. He had uncontrolled diabetes. When we actually tracked him, he was living under the freeway and, of course, had nowhere to store his diabetes. He ended up on dialysis. He ended up needing a transplant, but we were able to get him, by putting him in respite, get his diabetes controlled, get him into housing, and get him on that transplant list. Our return on investment, we pay for the beds, and our return on investment last year was 229%. This is actually quite low for us. The year before was 310. The year before that was over 300 also. What is happening now is we're deciding as a team to keep them longer because ultimately the solution to homelessness is housing, so we're keeping them longer. There is such a shortage of housing in New York City. We're a very densely populated city where any piece of land, it doesn't matter how small, it has high value. So people are not willing to build supportive housing. They would rather build, you know, apartments that are going to be market value and earn a lot of money. Our mayor has inherited a huge problem. He is currently opening 19 new shelters. And our hope is he would open 30 new shelters and maybe 60 supportive housing. But I think for all good intentions, his heart is in the right place, and he's really trying to do the right thing by patients. So that is it.
I'm sure we have questions out in the audience. Oh, there's one right there.
I have 2 questions, mostly for the Montefiore program. For your housing team, was it a dedicated team? That's one. And then new subject or new question, what is the formula for your calculating your ROI?
It is a dedicated team. It's solely to deal with housing and with the folks coming in. The return on investment is calculated on, we look at a patient that's medically stable for discharge. We look at the amount of days post-medically stable that they're in the hospital. We calculate and we use a very, very conservative number of what that would cost the hospital per day, and against what it costs us to put them in respite, which is very, very minimal. And also what we're missing, the money that we can't generate by putting somebody new in that bed.
It's a question in the back there.
Thank you. My name is Gil Harrison. I'm a volunteer at Sharp Memorial Hospital and involved with the Community Care Partner Program. Sometimes we visit patients who don't have family. Not only that, but they're also illegal. Have you ever encountered any of those problems, and what did you do about them?
Anyone want to start? You want to start?
So we have been working with a couple of other hospitals. Our hospital co-founded a consortium, the Bronx Health and Housing Consortium, where we work with other hospitals in the Bronx, with our managed care organizations, with all of the housing partners in the county. And we've come up with guidelines for what we consider a diligent search. And it's numerous ways of trying to find a family member, trying to find somebody. With our undocumented folks, if we take them into respite, we're very clear that unfortunately, because of their status, we cannot get them permanent housing. They can come in, they can recuperate, and then go. The only other avenue would be to the shelter. However, we do work with the New York Legal Health Group, and some of our undocumented folks could qualify for PRUCOL, persons residing under color of law, and get a legal status that way. And so if we have a case that we feel would qualify for that, we send it to that legal health group and they try and pursue a legal status for them.
Yeah, this is one of the reasons we partner first. We don't track immigrant status, but we have federally qualified health centers and navigation nonprofits that really work with the clients. We do not deny services because of status, and they can move into interim care. And we have a number of housing options. So we have the temporary, but that's a balance in California and across the state because they can't be housed over a certain amount of time and remain homeless, right? Then they're considered housed. So we really look to our partners to manage that, and it seems to work for us.
So like Sutter, we do not deny care to someone because they are undocumented. We, again, partner. We do a lot of work with AmeriCares here and what they can provide, as well as the local FQHCs. If it's the right place and they qualify, we will put them in medical respite, but then we are faced with where do they go after medical respite. And we don't want to clog up a medical respite bed for too long either, because then it's denying other people the bed. So it's a dilemma. It is a dilemma.
Carrie, you mentioned street nurses. Can you talk a little bit more about that? Do they go out by themselves? Their licensing?
So I'm actually going to turn this over. My colleague, Holly Harper, is here. Can you stand up really quick, Holly? She's Director of External Affairs, and now leads all of our community health programming?
Thank you for that question. Our street nurse model has been, I'm going to call it very unique, and it was in response to many of the things Carrie talked about. Obvious need. And there are core centers of Sacramento where our homeless population is. And so we worked with WellSpace Health, who you saw in the video, who manages our interim care program, and used them to hire registered nurses to go out on the streets. So I think what Carrie mentioned earlier is it's a lot about that relationship building, and I think everybody up here has alluded to that. It's about the relationship and the constant contact. So these are registered nurses who go out on the streets, truly with backpacks on, and say, hey, Bob, that looks bad. Let's get you to the emergency department. And if Bob doesn't need to go, they help him there. They can also help with medication. Sometimes they can refrigerate the medication for them. Then we mimicked the model in Modesto and Los Banos, very different populations, high immigrant farm worker populations. And so they have actually expanded it to go out there with behavioral health and a mobile clinic. So it's a unique model. There are some FQs too that will claim to be able to bill for that, and some FQs won't. So there are rules around FQHCs. They can bill within the walls of their hospitals, and some will and some won't. So the models are different depending on the community. Does that answer your question? Okay.
Any other questions out there? I want to kind of dig into the mechanics, if I could, with each of you, because you're right. Everyone has talked about partnership, collaboration. I think for those of us that will start with the implementation of our new law come January and July of next year, we know that we can successfully get the work done if we have the appropriate partners. It really takes the partnerships. Could you talk a little bit about what the start of that looks like? Who invites who? How do you get them to come together? What's the invitation look like?
So it can be a little messy, and it can be a little uncomfortable, and that's what I found with interim care, because I think people see our earnings, our executive salaries within healthcare and hospitals.
Tell the truth, Carrie.
I speak facts. It's not from a place of judgment. I love working at Sutter in healthcare, and we do a lot of good, but they see that, and so they think we should solve the problem, and that's the legislature, that is other business leaders, that is nonprofit groups, that's advocacy groups. And so for us, we extend the invitation. In the Sacramento region, and this isn't true in other parts of our valley, but in the Sacramento region, so the 6-county region, we have 4 not-for-profit healthcare systems, UC Davis, Kaiser, Dignity, and Sutter. We don't see in our line of work us as competitors, so we come together a lot and work on this stuff together. And really identifying for us the key partners that can deliver the outcomes, that are nimble and that respond to community need, and will kind of have our back as we have theirs. We do a lot of test grants with nonprofits, so we'll give them a small grant to see how we work together and bring them in with our care providers, which is key. We really need those ED and inpatient physician leaders, nurse leaders, and care coordinators. But we have regular meetings with them, roll up our sleeves and work through issues, and we make sure to understand what they need. I think it's really important as healthcare to not expect them to solve all of the issues. We need to be very clear and define what it is that we need them to do for us. And we need to engage with them in a financial contract that allows them to do that. Because I think so often we look at nonprofits and we immediately think that they're not doing enough or good. And I know internally a lot of times Holly and I are bringing down this expectation that they're not taking a referral and they should. Guess what? The referral wasn't right based on our agreement. Mm-hmm. So it really is defining that and respecting what they are supposed to do and giving them the space to be successful so that we can partner.
Deirdre or Jeanette?
So we're tiptoeing into the room. We're not running into the room with our partners. We're tiptoeing into the room. And I think the direction we're going in is trying to do a better job of formalizing these partnerships, in some cases through contractual arrangements. One of the things we've learned is we have a system in the state of Connecticut, Patient Ping. I don't know if you have that or something similar to that, where we subscribe and we send ADT messages when any patient comes into an ED or is admitted an inpatient. Same for skilled nursing facilities, home health agencies. And so what we've learned and are continuing to learn is that these are all our patients. We share these patients. We're actually quite amazed at, we think somebody is a high utilizer, we're amazed because they're not just high utilizing in our system, they're high utilizing in other systems throughout the state. So that's great impetus for us to work closer together. So again, I think it's working towards more formalized agreements because then you have better or more concrete definitions of the expectations on both sides and what each is bringing to the table.
And I think for us as a hospital, we did it really kind of boots on the ground. We went out, we went into the shelters, we went to our community-based organizations, and we went under the guise of, you are the experts in housing, you are the expert in homelessness, teach us. You know, teach us what we need to know. Teach us how we can make your life easier when your patient comes in, when we're doing something. Teach us what we should do. And really just building relationships like that. It then morphed into the Bronx Health and Housing Consortium, as I mentioned before. And we conduct we go into the supportive housing, we'll educate them on end-of-life care, on palliative care, and doing advanced directives with the homeless population, on sickle cell disease, whatever they need. If they say, we don't understand this, our direct care workers are having a difficult time, we'll put a presentation together, we'll go into where they are, and we'll educate them, and we have them do the same thing. We have them come into our hospital and educate, you know, staff in the hospital, the physicians in the ED, on homeless patients, you know, what's the best practice, what's the best approach, and it's really networking, and it's really, you know, if you say to somebody, can I call you, and you call and they answer the phone and they return the phone call and they call you in the middle of the night saying, I can't find my patient, can you help? You got to answer your phone. You got to, you know, you got to do it. You got to answer your phone. And we found face-to-face works the best. We have interagency case conferences in the hospital where we invite supportive housing partners, managed care organizations, because we do share the same patient. And when we have a complex patient, we have quarterly case conferences and say, here's the themes we're seeing with our patients this month. What can we do about these patients with severe behavioral health problems? What's available? And we educate each other and work together.
One other thing that could help, because we all do community health needs assessments every 3 years, that's a great place to start, to bring people in and talk about what we've seen in data, what they're seeing in the community, and it's a way to open a conversation.
Great. Any questions out in the audience?
So I wanted to ask a question about kind of, you started talking about it a little more, maybe you could, you talked about it, but maybe you could talk about it a little more, kind of trust building between community organizations and hospitals. So I've kind of been on both sides of the fence years ago, or for many years at a large homeless shelter where, you know, trusting the hospitals was not necessarily the first thing that came to our minds. And now at a hospital where, you know, I'm kind of on the other side of the fence and appreciate how challenging it could be, and, you know, that hospitals reaching outside of their walls is not necessarily what they're the best at. So, and it does seem that a lot of these partnerships you've talked about really are going to be most successful when there's kind of the trust on both sides that each side's going to come through when the other one needs it. Maybe, and I think that gets a little bit to your mechanics that you were talking about. I was wondering if you could maybe talk a little bit about some of the hard work that you've done in that area.
Yeah, I can definitely say it wasn't pretty in the beginning. When I went into some of the housing providers and said, how can we help? And they said, stop dumping all your folks into the shelter. And the Department of Homeless Services were very clear, like, you are sending the wrong type of patients. You're sending sick patients into the shelter that shouldn't be there. And it really was sticking with it. Like, showing up every single time, listening, a lot of listening, and a lot of explaining, and taking folks. We've taken folks into our ED on a tour of our ED because they just had no idea the volume in the ED or what the ED looks like, and they couldn't understand if we have one social worker overnight, why didn't that social worker speak to their homeless patient? Well, we had 3 child abuse cases that night, and that took precedent. And really, you know, a lot of communication, a lot of humble pie, a lot of, like I said, answering the phone. You've got to be accountable. If we promised, if you call us with an issue, or if you call us with an issue with your patient, you can call our team. We will track that patient in the hospital for you, and we'll find out the information you need. And if that patient should not be discharged back to you, we'll work with the inpatient team. And it was really following through on those promises. We've done things, yes. We've done things too, like with our large federally qualified health center partner. We've invested a lot in their brick and mortar clinics, but also sent in our JCAHO team so that they could become certified. They could get their JCAHO certification, and we took them through mock surveys. We have offered, not pushed, offered expertise within the organization. I think, too, it's just showing up. So many just appreciate you showing up, and this is hard for hospitals, not being the expert on everything. Just because it's pressing to us, you know, doesn't mean that we have to have our issues solved. It's finding those common issues that we're both working on, building the trust, and then building programs from there. I mean, our first program was the interim care program, which fed into T3, which fed into the ED Navigator, which went into Street Nurse, and it just kind of kept evolving. So staying really flexible and honest and just available is huge.
You said showing up. I was going to say sit at the table. You have to sit at the table, and it's not about excuses. It's about accountability. You know, as I said, with the Affordable Health Communities, we actually applied for that grant in partnership with the 2 large FQHCs in the New Haven area. And we're actually taking it a step further, and our primary care clinic, or 2 adult, we have 2 campuses. Each campus has their own primary care clinic. We are actually moving both FQHCs and both primary care clinics to the same location, and they are joining forces, and that's going to happen in 2019. I'm not going to say that happened overnight, but that was, we kept coming and sitting at the table and keeping the dialogue open.
So I want to ask Deirdre a curiosity question, if I could, but I want to make sure there's no legislators in the audience, because this could be dangerous. So you mentioned just real quickly that you have very strict regulations about discharging when and if and how. So could you, was that legislation? Tell me what that's about.
So New York, like I said, has a right to shelter law, but they also make it extremely difficult sometimes to discharge the shelter. You have to apply for a reasonable accommodation for everything. So it's not that there is any legislation from the Department of Homeless Services. They feel that, you know, and it has been our current shelter director and her predecessor feels if a homeless person enters the hospital and is there for more than 3 days, there's something, you know, they have a chronic condition and they're no longer eligible to be in shelter. It's extremely difficult. They will just say no. They will return the shelter referral packet. We will be issued a citation if we send a patient from the hospital to the shelter without having sent a shelter referral packet and without having gotten that packet approved. If a patient leaves AMA and shows up at the shelter, it's considered a community referral. But they will also backtrack that patient, especially if they show up and there is something medically going on with the patient. They'll backtrack with them, and if they found out what hospital they came from, they will still issue a citation to the hospital from the Department of Health saying you discharged a patient that's not eligible for shelter.
Okay, well, something to watch out for. As we move into implementation of 1152, I think we're all concerned about the quiet good work that we've been doing in our hospitals, taking care of all of our patients, doing the discharge planning, trying to collaborate with our community partners. It just feels like we're going to enter into an era now where there are some enforcement penalties that might come when we're doing the best that we can. There always seems to be a misunderstanding, and I found this while we were negotiating the bill, that these are patients that can decide what they want to do. You bring them in, you start work with them, and then suddenly they realize that if they stay any longer, all their belongings might be gone or something else might happen. So talk a little bit about that part of it, where these are patients that get to decide what happens next.
Yeah, they get to decide. They have free will. They also can walk out in a hospital gown without us being able to provide clothing, and that provides a nice media opportunity. We also have we have a safety issue for our employees and our other patients, and are really battling with the ejection issue of people who aren't safe to be around others and physically dangerous. And so that's something that we are really dealing with our kind of security and protection services unit. I think also when we talk about partnership, and none of us, I don't think, have talked about it, is really engaging the counties who are responsible to a certain level for this population. It's not easy in many of our communities. They're wonderful partners, but they have a lack of resources too. They're also, oftentimes counties are rural and kind of more urban, split on votes. So a lot of the homeless issues are more in the urban areas. So it is a struggle to educate, not a struggle to educate, it is a struggle, the free will and the safe ejections, but really getting to know your electeds and rounding on them regularly so you can tell the story and make sure they know that. We battled 2 local ordinances at the same time as 1152 was coming with the city of Sacramento and the county of Sacramento, thinking maybe we need local ordinances on top of. And we're able to go with the other healthcare systems and the hospital council to tell our story and have a meaningful conversation to say, let's not put an ordinance on it, let's partner in order to really try to address the issue, because all of these things, the food, the clothing, it doesn't get at the root cause. And so if we're all trying to end homelessness, let's really put our resources there.
I want to add to that.
I will just add about the capacity issue. If we have determined someone has capacity and is refusing shelter and walks out, we still send down the shelter referral packet to the central intake with the Department of Homeless Services, because we've gotten dinged in the past that we've had, AMA paperwork signed by the patient, and then they leave and it snows, and then they show up at the shelter and they've still got their wristband on from the hospital, and then they call the hospital saying, you sent this patient down to us without going through the proper procedure. So if someone leaves AMA, we tell them that, we really feel that they need to be in shelter, they're not safe on the street, and we'll still send that paperwork down, and we'll call the intake shelter director and say, this is what happened. We have the AMA paperwork if they'd like a copy, and we fill it that way.
Very good. So I think what I was going to comment on, and all of you have said this in your presentation, in terms of working with vulnerable population, not just homeless, but all our vulnerable populations, that you need to create a system of care. So each of you have kind of spoken about work that you do prior to anyone coming into your EDs or being in your hospitals, the work that you do within your hospitals, and then the collaborations and partnerships that you have. Anyone want to say, in terms of building that system of care, where you begin? Where's the best return on your investment? Oh, stump the panel. Okay.
I will say, It was easy for us with the respite to show return on investment because it's just easy math. You can show, look, if you invest in this, it's not a significant amount of money for the bed at the respite program. You are not only saving money, but you can generate money by putting a new patient in that bed. For the housing at risk program, it is extremely difficult for us to show. We can show like a reduction in ED usage, but that's our ED usage. They could be going to the public hospital and using the ED. We don't have a way of tracking that. And we've done it on the goodwill of the hospital. We had a really amazing associate vice president when we started this program who really believed in the cause and used savings from our accountable care dollars and put it into this program. And all our staff are salaried staff. It's not a grant. And they invested in that, and they really don't ask us. We do an annual report every year, but they've never asked us or given us a quota. You must house 25 people. They've just invested it. They want to do the right thing for the community.
Good. Back to the right.
So I would say where we start is data. So we start with community health needs assessment data. So really, what are the findings of the neighborhoods that we're serving, the needs of the neighborhoods we're serving, and conversations both within the walls of our hospital, of our care providers, and externally with our partners. I think the second thing is really the community will. Where are the nonprofits that exist that can meet the need, and or you can invest in order to raise them to meet the need. And lastly, political will, I think, is really important in this environment and kind of the work, that community health work.
Well, thank you. And join me in thanking our panel presenters today.